Call the meeting to order. Pursuant to Standing Order 81-4, main estimates 208-209, votes 1, 5, 10, 15, 20, 25, 30, 35, 40, and 45 under health, referred to the committee on Thursday, February 28, 208. Today we have the Minister with us. Minister, you've been here before.
I have.
We'll have you give us a statement, and then we'll go through the questions. Pleasure to have you with us.
Well, thank you very much, Chair, and welcome as well to members of the committee. It's always nice to be here. I am addressing the health portfolio's main estimates for 2008-2009, of course, and I have with me, and I'm pleased to introduce our Deputy Minister of Health Canada, Maurice Rosenberg, Alfred Sang, who's the Chief Financial Officer for Health Canada, and on the Public Health Agency of Canada's side, we have Dr. David Butler-Jones, who's the Chief Public Health Officer, and James Libby, who is our Chief Financial Officer. And I may, from time to time, if it pleases the committee, turn to them to assist me with any technical matters that might arise in answering your questions. Tout d'abord, je suis heureux de
To begin, I'm happy to be appearing before this committee during what has been a very active time for the portfolio. We're taking action and making good on commitments for a healthier environment, safer communities, safer food, health and consumer products, along with more patient-centred health care. In doing so, we're building from the expertise of our officials as well as provinces and territories, healthcare stakeholders, First Nations and Inuit community leaders, patients and industries.
Our range of partners needs to be broad because our policy spectrum is wide. Health policy is not just about working with doctors and nurses on dealing with illness, but working with all sectors of society on promoting health. As written in the Ottawa Charter, signed at the First International Conference on Health Promotion on November 21st, 1986, and I quote, "Health promotion goes beyond health care. Health promotion policy combines diverse but complementary approaches, including legislation. It is characterized by action that contributes to ensuring safer and healthier goods and services, healthier public services, and cleaner, more enjoyable environments," end of quotation. So, Chair, as you can see, these words do well at defining and explaining the approach of today's federal health portfolio, and therefore I would put it to you and the committee these main estimates. For instance, we know that more than 2/3 of deaths in Canada are the result of chronic diseases. These estimates thus contain an incremental funding increase of $8.6 million, for instance, for our integrated strategy on healthy living and chronic disease, which encourages healthy living and includes disease-specific strategies for diabetes, for cancer, and for cardiovascular disease. These estimates also include an increase of $2.7 million for new and ongoing public health information programs, including our Healthy Pregnancy Initiative and the Children's Fitness Tax Credit campaign, which, of course, raises awareness of the credit and encourages families with children under the age of 16 to be more active. In addition, I want to highlight that these estimates refer to $10.65 million annually to renew our response to hepatitis C. This will be spearheaded by the Public Health Agency as it works closely with community and provincial and territorial partners to implement a renewed prevention, support, and research program. Planning our preparedness in response to a pandemic also remains a priority. We are implementing a balanced, multifaceted approach that includes securing a domestic vaccine supply, as well as a comprehensive pandemic influenza plan. Stockpiling for antivirals, of course, and other public health measures are included to minimize the impact of a pandemic. Indeed, we have now reached our target for the purchase of 55.7 million doses of antivirals for the national antiviral stockpile, the number of doses estimated to treat all Canadians who become ill in a pandemic and who require and seek medical attention. On top of this, the main estimates contain a $28.3 million increase for a cleaner, healthier environment. This includes a $17.4 million increase for the chemicals management plan. Through this plan, we've committed to assessing chemical substances used by industry which are of potential concern. We are challenging industry to show they're using them safely, and we're taking decisive action to protect the public. For example, as a result of Health Canada's assessment of bisphenol A, that's a great example of how we have moved forward, because so long as no new compelling information arises during the current public comment period, we would be moving to ban the importing, selling, and advertising of polycarbonate baby bottles. The assessment found that when it comes to its use in producing items like hockey helmets and DVDs, BPA is not a concern, but when it comes to polycarbonate baby bottles, there's a risk that very hot liquids may cause the chemical to leach into formula, be ingested by newborns and infants, and possibly have negative effects on their development. And so, as a result, we're acting promptly on our knowledge and taking action to best protect our kids' health. So, Chair, our estimates also include a very important investment to protect the health and safety of our youth and communities as well. On April 29th, I had the pleasure of joining the Ministers of Justice and Public Safety in announcing $111 million for critical drug treatment and prevention initiatives for provinces and territories under the National Anti-Drug Strategy. Cette stratégie permet de renforcer les mesures.
Under this strategy, we're strengthening enforcement as well as treatment and providing help to parents in talking to their kids and protecting them against the threat of illicit drugs.
A contribution of more than $27 million to support our awareness-building efforts and implement our treatment actions. With the recent announcement of a $230 million investment over 5 years, our government is investing more than any previous government in order to safeguard Canadian families from illicit drugs. And alongside this unprecedented action for safer communities, we're also moving forward with action for safer products. As you know, the Prime Minister announced Canada's Food and Consumer Safety Action Plan last December. And although it's not covered in the main estimates and will be discussed later this year during supplementary estimates, Budget 2008 backed this plan with a 2-year investment of $113 million. On April 8th, we moved this plan forward by tabling Bills C-51 and C-52. Et ces projets de loi visent respectivement à moderniser.
Respectively, they seek to modernise the Food and Drugs Act, which has not been updated for some 40 years, and replace Part 1 of the Hazardous Products Act, which was written in the late 1960s. Together they propose important tools to strengthen Canada's approach to safety.
The important action that we need to take to better protect Canadians in a modern world, and I look forward to discussing them with greater depth with you, obviously, in the weeks to come as those bills come before committee. However, right now I want to address our proposed approach to strengthening drug safety under Bill C-51. Now, there are some out there that are maintaining that this bill will in some way weaken our drug approval process, and I want to say right here and now that this is not the case, and in fact, far from it. The current process calls for a vigorous assessment of health products before they gain access to market, and under C-51 that won't change. Sorry?
Mr. Chair, Bill C-51 will come to this committee at another time. This is about the estimates.
I'm sure the Minister doesn't have much to say about C-51 right now.
Sure. No, that's quite true, Chair. Let me just say that this government is for more safety, not less, and when these bills come to committee, we'll have an opportunity to thoroughly debate those bills, that's for sure. I want to emphasize that we know full well the immense importance of strong support for health research and health care, and our main estimates back this assertion with action. For example, we know very well that health research is the backbone of effective health policy. As a result, our main estimates include an increase of more than $59 million to the Canadian Institutes of Health Research. With this funding, CIHR will support excellent health research and turn the knowledge into concrete benefits for Canadians, including better health, a stronger healthcare system, and indeed a stronger economy. In addition, the estimates contain increases for quality health care. For example, there's an additional $60 million to address the health needs of the growing First Nations and Inuit populations and improve health care delivery through greater integration with provincial and territorial health systems. There's also support for the commitment we made to working with provinces and territories to develop patient wait time guarantees. En mars 2007, chaque province et chaque territoire.
In March 2007, each province and territory agreed to develop and implement a guarantee by 2010 in either cardiac surgery, cancer care, joint replacement, sight restoration, or diagnostic imaging. Budget 2007 provided more than $1 billion to support their efforts. More than $1 billion.
Which is included in our main estimates, is funding for interested provinces and territories for pilot projects to test innovative approaches to establishing guarantees. So far, I've had the pleasure of announcing projects in Nova Scotia, Manitoba, and PEI. So in closing, Chair, I'm very confident that the actions we're taking today within Health Canada and in research settings throughout Canadian society, and within these main estimates, along with the steps we're taking through legislation and regulation, we are getting results for Canadian families. Our government, I want to assure you, is dedicated to building a safer, better Canada, and the actions of the health portfolio are strongly supporting this objective. With that, I want to thank you again for the opportunity to provide my comments, and I would be pleased to take any questions that might crop up at committee.
As we're, thank you very much, Mr. Minister. As we're getting on with questions, I'm advised here by my very capable advisor, the clerk, that this will be in discussion of vote number 1 under the Health Act. Dr. Bennett, you have 15 minutes of questions
excellent.
and answers.
Excellent. Thanks very, very much. Thank you very much for coming. And it is always a pleasure to be able to sort of look at whether we're putting our money where our mouth is in terms of the most cherished program of Canadians. And my questions will deal with probably 3 areas. One around partnerships and relationships, then around actually the money, and then around, I think, the laudable new goal for the Public Health Agency around health disparities. So if I guess I'd like to just begin in terms of the rather lofty phrase on the beginning of your page 9 on Health Canada partner and interwoven community of stakeholders, that the number 1 bullet says provinces and territories who bear the primary responsibility for healthcare administration and have their own roles in health protection promotion. A strong relationship with provincial and territorial counterparts is critical in achieving our mandate. I guess I would first like to ask the Minister why then he cancelled the meeting with the other provincial counterparts in December and has again refused to meet with them even this spring at all. So, and particularly, I guess, in view of the rather damning report of the Auditor General in terms of being able to get agreements with the provinces on reporting of particularly infectious diseases, such that you wouldn't be able to report in a timely fashion to the WHO. The fundamental weaknesses in the surveillance system that she identified and is saying that has not made satisfactory progress on strategic direction, data quality. I mean, due to gaps, you're not, particularly at the Public Health Agency, receiving timely and accurate and complete information, that it's impossible to get a consistent national picture on infectious diseases, and therefore unable to obtain the information necessary to prevent and respond to a disease outbreak. So I guess I'm very concerned that if we can't meet around a table and negotiate this important next step, and particularly when the Public Health Network has been cited as one of the most important things in 30 years in Canada, that other things out of the 10-year plan, like being able to set goals and targets for improving the health status of Canadians through a collaborative process, that all of these things that require partnerships you seem to have not done, and sadly at the committee, as we're doing the post-market surveillance, it seems that the national pharmaceutical strategy has ground to a halt in terms of even the federal co-chair being not named. Tell me about how you're going to have a partnership with the provinces when they think they have no partner with you.
Sure. No, thank you for your questions. I appreciate that very much. First of all, it was unfortunate that the last federal provincial territorial meeting was cancelled. It wasn't cancelled by me. Unfortunately, the co-chair was Saskatchewan, and they, in fact, were having the election and then the post-election period in Saskatchewan with the change of government. So the collective decision of all the partners, including the provinces and territories, was that was not an ideal time. In fact, many health ministers cancelled out of the meeting before a decision was made by the co-chairs to not go forward. So I am very much looking forward to having our meeting this fall instead. And in fact, I can assure this committee that I've had many successful bilateral meetings with ministers of health. Just recently, this week, I met with the Minister of Health for Nunavut. Last week, I met with the Minister of Health for Alberta, and I can go through the list, but you can, and the Minister of Health for PEI and so forth. So that has been a priority of mine, to at least have these bilateral discussions as much as possible in the absence of a multilateral meeting. On infectious diseases, if I might just defer very quickly, I know you want to preserve your time, but if Dr. Butler-Jones can talk about the Auditor General's report, I think that would be helpful to the committee.
Yeah, certainly from our perspective, the AG's report was actually a good news story in the sense that she recognized that we have made tremendous progress since the formation of the agency. The areas that she focused on for further work were around formal agreements, as for instance. We do, for routine information, and the concern or the question that the possibility, didn't say it was happening, because it isn't happening. We are getting the information we need, but the possibility that in an outbreak that we might not get that information. The reality is that, as we saw with the people on the train in Northern Ontario last Friday, is that the system does work. We do get the information we need. We do coordinate and collaborate very effectively with the provinces and territories, and we have the processes and protocols in place. And I expect shortly we'll have those formal agreements for routine information sharing as well. And we do actually have an agreement for information sharing that all ministers have agreed to. We're just finalizing some final wording, but they have agreed to it in principle across all jurisdictions for the sharing of information in emergencies. And then finally, just to say that the WHO tells us that 40% of all their reports first come around the world come from us first, so that our surveillance system actually identifies things before the countries themselves know about it, and that most countries look to us as a model for how we do that work with provinces and territories. Thank you.
Mr. Chair, I guess I would just like to focus on the money now, in that it seems disappointing that with the aging demographics and the challenges, that the summary information shows that by 2010-11 that the ministry will have less money than they will this year. I don't know how one explains that the budget for the whole health portfolio goes down, but particularly in terms of the main estimates for the Public Health Agency would go down from 658.3 to 590.5. And I mean, I think it is extraordinary that things like health promotion, the planned spending could go down to 197 by 2010, that the money for public health capacity goes down, infectious disease goes down, emergency preparedness is the only thing that seems to stay. Is that not embarrassing? And I guess in the one thing that I'm sure the minister expected us to ask in that every day we're being asked by community organizations what is going to be the funding on HIV/AIDS. I wondered if the minister would like to tell me how many new HIV/AIDS infections there are per year and how he can justify cutting community funding and not even letting them know how much money they will have so that they are able to plan. So that these organizations want long-term, medium-term. They don't even know short-term funding now, and it's not clear in the estimates. I guess I'd like to know whether the money for the vaccine initiative has been used, and whether what the last time you met with the Ministerial Council on HIV/AIDS in terms of, what I think is their concern. So the community is furious, as you know. They don't know what to spend, and yet there are still climbing cases of HIV/AIDS in this country.
Well, thank you for your comments, and certainly I wish committee members to know that actually this year in the 08-09 budget we're spending more than $84 million towards HIV/AIDS, which is more than has ever been spent by the Government of Canada in our country's history. I think the budget cuts that the member is referring to are those that were found in the 2005 Liberal budget, which of course, despite the Conservative Party's position, was passed by Parliament, and we have an obligation to implement those cuts as a result of the 2005 Liberal budget.
With due respect, you have choices to make every year. And those were Treasury Board allocations, as you know, so don't go there. But explain to me why your overall budget is down for all of health and for all of public health in your projections. Like, it seems to be very difficult for you to go downtown and get the money.
Well, I think part of it is because there are sunset funding requirements that are found as a result of Treasury Board requirements. But you might want to say something, Mr. Sang.
Mr. Chair, there are indeed some sunset programs there during that intervening period. The flip side of that, there have been incremental funding announced, for example, in Budget 2008 that have not shown up in the main estimates only because of a timing issue. And equally, there are some, as I was saying, some sunset programs during that intervening 3-year period for which Health Canada may wish to seek incremental funding from the government too. So there's a timing issue related to that trend.
I guess the
sunset,
final thing.
Sunset is actually a passive activity. You can choose not to sunset programs, and things like the Primary Care Transition Fund, where people really had thought that was doing good work, you chose to let it sunset. These are ministerial decisions, and I don't think that the bureaucratese is very helpful to Canadians as to why this government would be choosing to reduce the budget for health and health care for Canadians over the next 5 years in both what they are able to do within the whole of the health portfolio, but particularly in the area of public health, in terms of what we know is the #1 goal of Medicare was to keep people well, not to patch them up once they get sick. This is a shared responsibility. How on earth can you defend that the money's going down?
Sure. Well, as I say, there are sunsets, there are one-time expenditures where the budget goes up and down depending upon the one-time expenditures. But to say that we're spending less on health care is actually false. When you look at the 10-year accord that was signed, which we have implemented, that means extra transfers to the tune of $1.2 billion to the provinces this year alone, extra for health care. You mentioned the Primary Care Transition Fund, but that was part of the 2004 deal, which you were a member of that government that signed that deal, which in fact wound down that program. So I certainly feel no need to defend your decision.
I think so, dear. Okay, in the Public Health Agency on page 9, the notable changes was that healthier Canadians reduced health disparities and a stronger public health capacity. Now, we've already just dealt with the fact that the budget for public health capacity is going down, which I don't really understand at all. But I guess I'm most disturbed that in terms of the program activity for First Nations Inuit Health, that again, the planned spending for 2010-11 is dramatically reduced in terms of gross expenditures, as is even the number of people doing it. And in terms of what we've known is in terms of equity and the things that work the best, the health human resources of our Aboriginal people. This is the $100 million I've asked you many times about. How many more Aboriginal physicians, Aboriginal nurses are we able to show for the $100 million that was put into the health accord, and not just cultural sensitivity and nice things that we want all Canadians to do, but how many more Aboriginal nurses, how many more Aboriginal doctors do we have in this country, and how on earth can you be reducing the money to when in the program activity on First Nations Inuit Health at the same time as you are saying that you want to reduce health disparities, and we know that this is the biggest embarrassment for our country, the gap in health status of our Aboriginal peoples.
Sure. No, thank you for that. Just to give you some raw statistics, through the Aboriginal Health Human Resource Initiative, which, as you say, has been funded, and we support that, we've been able to more than triple the number of Aboriginal healthcare students receiving support. So there's over 1,100 bursaries and scholarships that have been awarded in the program, and over 60 Aboriginal medical students are part of that funding. So I believe that we are being helpful to the needs in the community. There's no doubt about that. And as these estimates show, we have in fact injected many tens of millions of dollars more into First Nation and Inuit Health Branch for the provision of services. We know that the populations are rapidly increasing to a greater extent than the population as a whole, so that we have more people who need more medical services, and we're certainly trying to, at the same time, transform the system, because I have a great deal of concern about the sustainability of the system for First Nations and Inuit Health, and that's why we're working with the leadership and the provincial leadership to try to get to some better health models and some better health results. So I think we're on the same page on that.
Except that on page 66, the gross expenditures for First Nations Inuit Health Programming and Services goes down.
There was a one-time. In each budget there's a one-time expenditure that seems to be added onto this budget. We have a one-time expenditure this year that goes towards meeting the services, but also goes towards this transformational funding that is designed to help us get to a better place when it comes to the long-term sustainability of the program. So as the program gets transformed, then of course you don't need the transitional funding for that transformation.
Thank you.
And that explains 150 less staff.
Thank you very much, Minister, and thank you, Dr. Bennett. We'll move on to Madame Gagnon pour 10 minutes.
Merci. Je vais poursuivre aussi.
Thank you very much. I'm going to continue on the clientele issue. You're responsible at a federal level for Aboriginals when it comes to healthcare. This week at the committee, we had the Wait Times Alliance come before us. It's an organisation that provides indices and on assessments that they've carried out on objectives on in relation to the 10-year plan and wait times. Now, as far as Aboriginals are concerned, there was no data submitted on the follow-up of the 5 priorities on the wait times, on operations, and that is the 5 priorities. So for several times I've tried to ask witnesses who've appeared before the committee about the 10-year plan. I've asked some questions in relation to this. Now, in your response to my colleague, Ms. Bennett, you said you want to revolutionise the healthcare system. But a witness said to us that when there's no statistics, it's very difficult to assess whether things are being revolutionised. So I'd like to stress Aboriginals. Given that you are responsible for the health of Aboriginals, it's not a provincial area of jurisdiction. What do you do to address what are you doing to address these shortcomings? Are you getting your hands on statistics? Do they need more support? There's a cutbacks in the main estimates. Can't you help them more than you're currently doing so? In a couple of years, is there a likelihood that there'll be a new that you won't have met the objectives that you would have hoped to have reached? Well, let me say a couple of words about that. To begin with, most funding for access to hospitals and healthcare for Aboriginal persons it comes out of provincial and territorial envelopes. It's not direct funding. And the same is true for wait time guarantees. When we announced wait time guarantees in conjunction with the provinces and territories, each province pledged implementation of this with guarantees. And this is to ensure that Aboriginals experience wait times that are the same as the general population. Now we've announced pilot projects on reserve for Aboriginals, pilot projects for guaranteed wait times, for example, for maternal issues. And the program targets Aboriginals on reserve primarily. I think that all these programs are going to improve the situation. We're not talking about one single program or one single system. We're talking about a strategy among our whole host of strategies. With all the due respect, Minister, I am not really convinced about the human resources efforts and funding efforts that are being made to give a hand to this clientele which falls under federal jurisdiction. On several occasions I called for an inquiry as to the healthcare of Aboriginals in this committee, so we will have witnesses come before us at some point. I think that there are warning bells being sounded about demand and the support that might be afforded Aboriginals to improve their health. So at that point we'll have an opportunity to see you back here again so that you can give us a far more pessimistic so that we can hear a far more pessimistic overview than that which you've given today. Now, you announced 59 million for health research institutes. We met with a number of health care researchers. Some of them said that there was an increase in requests for research studies, but there are a number of research projects that were denied. Now, I'm just looking for the right word here. So a number of research projects just quite simply didn't qualify. How is it that so many research projects are denied? And why is there a lack of funding? Sometimes there are research laboratories that have to cut back their activities, or sometimes they even have to shut down their research activities due to a lack of funding. Now, you said you increased the budget to the tune of $59 million for health research institutes, but perhaps the money isn't being properly allocated. Well, the government is supporting more than 11,000 researchers across Canada for health research. Of course, there are a lot of world-class researchers in Canada.
For these grants, there's no question about it. But we think that by adding to our totals and by creating, I should say that there's a number of measures. There's a new Canada Global Excellence Research Chair Fund, which I think will be helpful in a lot of these. We're putting more money into Genome Canada. I know we're funding stem cell research directly as well. There's a lot of very exciting things that our researchers are involved in that are world class, and certainly the Government of Canada has proven that we can be part of the solution. Maintenant nous avons une nouvelle.
We have a new policy for science and technology strategy. Now, the strategy is important to our future success in terms of the economy.
In healthcare as well as many other areas.
Ben, disons que certains chercheurs nous ont dit que le taux de réussite.
Some researchers said that the success rate in their application approval rates dropped markedly from 2004 to 2007. That's a drop in 8.7% over that 3-year period. So clearly, things aren't looking good in terms of the figures, and these figures testify to the situation they face. They'd like the approval rate to be up at about 25%. So we don't need 30%, but at least 30% approval rate for requests and applications. Some research is well worth it, and especially in some areas, and currently researchers just can't make ends meet. I visited a number of small research centres, and they have small teams, and they have to just scrape by with the... Well, in fact, there's been a change in leadership heading up this agency.
As a result of his leadership in Quebec over the last few years. I'm quite confident, j'ai confiance qu'avec cette leadership.
I'm quite confident that with this new leadership that we'll be able to work together on this challenge. Of course, there are challenges that need to be tackled.
Worldwide perspective, Canada is doing very well. We're considered a world leader in medical research. It's something that we want to continue. Its medical research has been identified as one of the top priorities in the science and technology strategy. So we will continue to make efforts for sure.
Mais il y a certains chercheurs qui quittent le Canada pour aller ailleurs.
Some researchers are leaving Canada to go elsewhere because they can't continue their research. So we have a different perspective, a different take on things, Minister. Now, Minister, you said that you want to invest in illicit drug and drug abuse prevention programs. You said that you have a very clear strategy. But we're concerned because you took a book off the market which dealt with reliance on drugs and prevention matters. You know, in Quebec, there was an outcry in many communities, the police community, for example, so a number of stakeholders, university professors.
Vous avez été étiqueté
So you said that you wanted to veto this because it's a matter of principle. You seem to not be open to this, and you said it's a step backwards in terms of the reality of the situation. So we announced a new national strategy, an anti-drug strategy. It's important to have a strategy for prevention and treatment. Now, we announced investments for this strategy. And I think that former strategies won't work for the future. The old strategies won't work. That's our decision that we've reached, but it's a decision that was reached with the public.
Thank you. Mr. Fletcher, since Madame Mouchali-Salis will be absent for a few minutes, don't get excited, Minister. She is coming back. Mr. Fletcher.
Thank you, Mr. Chair, and I'd like to thank the Minister and his officials for coming to committee today. Well, I think I'll follow up on some of the themes that the bloc brought up. Minister, our government has announced the Mental Health Commission and a national anti-drug strategy, and they seem to have some crossover at some level. So my question is, as you know, we committed $110 million over 5 years to the Mental Health Commission to study the most effective ways to address mental health and homelessness. The commission was set up to do research projects on housing and other types of supports in major centers like Vancouver, Winnipeg, Toronto, Montreal, Moncton. My first question is, what does the government hope will be achieved by the Mental Health Commission as they undertake the research and in areas of homelessness, mental health, and addiction? And I also like to ask how it fits in with the national drug strategy. Our government announced $64.3 million over 2 years, and that strategy is designed to reduce and prevent the use of illicit drugs, particularly among youth and Aboriginal peoples, treating those drugs with drug dependencies, and combating the illicit production and distribution of drugs. As you are aware, Minister, there have been many questions from both the media and members of Parliament about what the government is doing on illicit drugs in Canada, particularly on Vancouver's downtown east side. What is being done to address illicit drug use across Canada in these vulnerable communities, and how does it tie in with the Mental Health Commission, or is there a tie-in? There may not be.
Yeah, actually there is. Certainly in a lot of distressed communities where there's a high percentage of addicts, it's not just an addiction issue, it's a social supports issue generally. So we feel that there has to be a national body of research on this. That was the money accorded to the Mental Health Commission so that to pursue the pilot projects that you mentioned. And it will create a national body of knowledge on how we can, through effective housing programs and social support programs, also have an impact on reducing addictions in some of these urban centres. Obviously, it's not the whole solution for all of Canada, but I think it's a good start in dealing with these areas. And of course, one of the areas that we're dealing with is the downtown east side of Vancouver. It's no secret that is it's a distressed community with over 5,000 injection drug addicts in a few square blocks. So, but at the same time, there's lots of people who do some wonderful work there. So we're going to be supporting them through treatment programs. We're going to be supporting them through these quick response teams that we have funded based on the announcement yesterday. And of course, we're working in partnership with Vancouver Coastal Health Authority, with the Mayor's office in Vancouver, and with the provincial government. So there is a tie-in. You're dealing with not just an addiction issue or a homelessness issue. You're dealing with a whole lot of social distress, and that's why you have to look at it from a comprehensive point of view.
Well, certainly I've heard many positive comments about how this government's looking at the whole perspective of the challenges in the Vancouver East Side, but across Canada. So I think we're definitely on the right track there. To change gears a little bit, Minister, it's unfortunate that the opposition members are heckling. I wish they would respect our ability to ask questions to the Minister. Many provincial governments have undertaken sustainability reviews of their publicly funded healthcare plans in the past year. The governments of British Columbia, Alberta, Ontario, Quebec, New Brunswick, and Nova Scotia have all concluded their reviews. With British Columbia announcing new legislation, the BC legislation seeks to enshrine the 5 principles of the Canada Health Act and add another principle, sustainability. I wonder, Minister, if you could give us a perspective on the government of Canada's plans for the Canada Health Act and how we are supporting the provinces to ensure the Canada Health Act goals are being achieved.
Sure. Our party and our government supports the pillars of the Canada Health Act, the principles that are enshrined in the Canada Health Act. Of course, provinces are finding the need to innovate their healthcare systems, and we support that. Quebec has done some quite far-reaching things in their system, and you mentioned the other provinces, including British Columbia, New Brunswick, Nova Scotia, and so on. So we have to. We do support those initiatives. Our one proviso, obviously, is that they have to be consistent with the Canada Health Act. But my view is that it is perfectly possible and appropriate to do a whole lot of innovation. You can do so within the Canada Health Act. There's lots of innovation that can occur to increase accessibility, decrease wait times, improve management, improve accountability, improve sustainability. All of those things can be done within the CHA, and we're very supportive of that. When provinces come to me, as they do frequently, and say, look, we're thinking about doing this or we're thinking about trying that, I try to be as supportive as possible so long as the principles of the Canada Health Act are not violated.
Minister, there was some question from the opposition members about the public health funding. I wonder if you could share with us how the Canadian Partnership Against Cancer, the cardiovascular strategy, and how they are reflected in the estimates. And also, I wonder if you could also expand on the action the government's taken on trans fats and sodium. That seems to be the topic of conversation amongst many people in the cardiovascular community. And given today's hypertension week, it seems like an appropriate time to ask you the question.
Sure. Yeah, in terms of the Canadian Partnership Against Cancer, obviously there has been funding for that. There's also funding for research, for instance, about $124 million going to cancer research this year. The strategy that involves, and you were involved with this, of course, in your days in opposition, so I want to publicly commend you for all of the spade work that you did for the Canadian Strategy for Cancer Control. It's, as you know, it's broadly based, it's multifaceted. We get the province at the table, we got cancer societies at the table, and oncologists and cancer survivors. So I really think it is the wave of the future in terms of how we want to proceed. And indeed, it is animating our discussions on other disease-specific national initiatives, such as the cardiovascular strategy that you mentioned, which is probably a couple of years behind the cancer strategy, but is rapidly catching up on how to deal with that. The diabetes strategy has been retooled and revamped, for instance. And you mentioned some of the work that we've done on the trans fat issue, which was a very hot issue around this place, as you know, a few years ago. And it created the avenue for creating the Trans Fat Task Force, which we received when we were in government. We approved of their recommendations, and we've been busy working with them to reduce the incidence of trans fat in a number of different food suppliers. And in fact, it seems to be working. There's a lot less trans fat around now. I think it's been reduced by over 50% already, and we look forward for them to be meeting their goals in the next couple of years.
How much time do I have left, Mr.
Just
Chair?
a short one.
Okay.
Minute and a half.
On the chemical management plan, Minister, when we recently banned bisphenol A for baby bottles and things of that nature, that announcement, I think, touched a lot of people. I have a brother in California, and he actually heard about that announcement on the mainstream news in California, and he says he never hears about Canada in the news down there. And I wonder if you could tell us where you think the chemical management plan is, where it's going, the costs associated with that, both upfront and the cost of not doing it.
No, thank you for that, and you're quite right that the bisphenol A announcement was carried worldwide. If mimicry is the most sincerest form of flattery in politics, I noted that Senator Hillary Clinton introduced a Senate bill basically mimicking what we're doing here in Canada, so it must be right if she's doing that. But in looking at it, though, that was just one piece of broader strategy, which again is world-leading, called the Chemicals Management Plan. We reviewed over 25,000 chemicals legacy chemicals, as they're called. We identified 200 high-priority chemicals that we wanted to get some research on immediately. The next stage, there'll be another batch, you should know, and I guess maybe I'm releasing this a couple of days early, but there's another batch that will be gazetted in the next couple of days. Another series of about 16 chemicals, I believe, that that we've got the research back, and we'll be making some decisions on those as well. So,
thank you very much, Minister.
Yep.
Thank you, Mr. Fletcher. Now we move on to Susan Cadiz.
Thank you, Mr. Chair, and welcome, Minister. I'd like to ask you, it certainly is the federal responsibility to work with the provinces to ensure that there's surge capacity in the event of a pandemic, and yet I'm not seeing anything in the estimates that would help hospitals cope with the demand for beds and care in the event of one, and or to build the pressure rooms they would require. Could you please explain how your plan that you referred to before for pandemic preparedness addresses the matter of surge capacity in Canadian hospitals? As I'm sure you're aware, in Ontario, Dr. McGee of Mount Sinai and others in Calgary, etc., have raised serious concerns about the lack of surge capacity.
Sure, I'll take a maybe stab at that and leave the rest to Dr. Butler-Jones. But certainly we are doing things within our federal mandate, and one of those, as I mentioned, was the antiviral stockpile, which is now up to the level that has been recommended by scientists. The work that we've done on vaccine initiatives for pandemic, and of course the structuring of our response on a national emergency plan, which we constantly work with the provinces on. So that's we are responsible for our own jurisdiction. The provinces obviously get increased transfers every year from the federal government, which they put to good use in their hospitals and their doctors and nurses and so forth. So that's how we help contribute to fund hospital capital and the surge capacity. But you might, Dr. Butler-Jones, want to add to that?
Yeah, just very quickly. Again, within the federal role, given the provincial responsibilities, in addition to coordinating activities so that we have a collective response nationally, we also have been adding to the national emergency stockpile in terms of masks, antivirals, etc., to go beyond what the provinces and territories, what we've done jointly, to have that as a backup and support to that, as well as the facilitation of cross-jurisdiction licensing. We now have, we shortly will have, we have an agreement in principle again around resource sharing and between jurisdictions during public health emergencies, etc. We're also developing a public health core, in other words, capacity that was out there from a federal perspective to assist provinces as appropriate. So in the ways that we can do that within our jurisdiction, we're continuing to try and build on that.
Okay, thank you. If I have a little more time, Mr. Chair, I'd like to know what is the expiration date of the Tamiflu, that stockpile that was purchased by the government in 2006, and what is the contingency after that expires?
Okay, two things. One is they're variable dates because they were purchased at different times, and so normally the expiry is 5 years, but we're working with the manufacturer and researchers and others to identify, because we think the actual shelf life will be much longer, and that there are other strategies to deal with that. In addition, we're in ongoing conversations with the provinces and territories about how to renew that when that is required, if that is required, into the future.
And just finally, we heard recently in last witness and testimony that we're not anywhere near reaching our goal with in terms of electronic health records. Is I think 5%. We're trying to reach a goal of 50%, I think by 2010, if I'm not mistaken. How are we going to reach that goal? I know we had begun that process, our government. You have added somewhat to it modestly, but the question is, we're so well below the goal, and it's such an important driver of improving Canadians' health and the healthcare system. Everyone is doing that globally. How can we expedite this?
Sure.
And I believe more steps should be taken. I don't think we're going to reach that goal if we don't. What are your plans to do that?
Sure. No, thank you for the question. And I think the 5% number actually deals with the family physicians. That's not a system-wide number. But in any event, you're an Ontario MP, and of course so am I. I think we can honestly say that Ontario has to keep moving forward. They have not reached some goals. But if you were to travel to Alberta, for instance, and British Columbia, and province of Quebec, other places, you'll see that there's been a lot of movement in these areas. Basically, for instance, the Capital Health Region in Edmonton and North in Alberta is going to be 100% EHR by the end of this year. So there's a lot of improvements happening. Our goal, of course, is to make sure it's not lumpy, that we've got to make sure that happens throughout the country, and that's why InfoWay Canada is part of the solution.
Okay, thank you.
Thank you very much. We move on to Mr. Brown.
Thank you.
5 minutes.
Thank you, Mr. Chairman, and thank you, Minister Clement, for being here again today. I've got 3 questions. I'll just let you delve into them. I remember having a conversation with you once about recruitment initiatives that the federal government has for doctors and the funds that were actually allocated over a 4-year period. I found that to be intriguing, and maybe if you could share that with the committee, because frequently in small towns we hear about physician shortages, and to hear about the role the federal government is playing in recruitment, I think something that needs to get better known. Number 2, I know at my hospital, I always ask them, what are your issues, so I can raise them at the health committee, and they certainly mentioned lots of areas of success they're seeing with the influx of funds for wait time reductions. But one issue they raised with me is that they're always at a capacity. 96 to 98% of the hospital beds are in use. I think that's sort of a problem that is common around the country. Do you have any thoughts on the capacity issues that hospitals are facing? And my final question, Minister, is I understand that you had Dr. Kelly Leach produce a report on healthy ways for children, and I understand that you have actioned some of her recommendations, and I think that would be interesting for the committee to hear about too, because I think that's a certainly good news story for how we're helping the health of young Canadians.
Sure. Let me just say a couple things about recruitment. One of the bits of good news that perhaps needs a little bit more media attention is the fact that we're always worried about the brain drain when it comes to our physicians, for instance, going to the United States. But for 3 years in a row in this country, more physicians have migrated from the United States to Canada than have migrated from Canada to the United States. So we're actually winning the brain drain war. We're actually getting the brain gain. And so that's, I think, a very positive step. More has to be done. As you know, we've increased our transfers to the provinces, but we've also got a $38 million per year strategy, health human resource strategy with the provinces. Part of it deals with international medical graduates. Part of it deals with focusing where the recruitment and retention should be advanced. So we are going to continue on that, and I want to see some results out of that. I just don't want it to be money that is thrown away. So that's certainly one of the things that I'm working on. The capacity issue is a big issue in the hospital system, and what a number of provinces are doing is starting to increase capacity by pushing some of hospital-based functions into community care, for instance. That's what Ontario is doing. BC has a strategy on that, and I think Alberta will be going down this route a little bit more too. So certainly we're encouraging of that. When we as the federal government on behalf of the federal taxpayer put in 25% of federal funding, that's something we're always very interested in and certainly do support. Kelly Leach's report, Dr. Leach's report, focuses on a bunch of things, including injury prevention, for instance, for kids, and some other child and youth some specific policies. Obesity issues, for instance, that was raised earlier in the committee. Obviously we're examining those very closely, and we believe that there's a number of things that we can implement. This level of government has never had a comprehensive strategy for child and youth health and wellness, and we're going to try to pull together a number of different departments in government as well as things within my ministry to accomplish that goal.
One thing that I've heard in conversations with physicians in my community is when they talk about the physician shortage, they reference in the early 1990s when the then NDP Premier, who's now a Liberal MP, actually cut spots at medical schools, which was horrific for the physician population in Canada. And one thing that's great to know in having you as health minister is that I remember you actually opened a new medical school in Northern Ontario, which I think was a great step forward, because one of the recognitions is, as much as there's a shortage and we can recruit from elsewhere, until we have provinces open up more medical schools, there's going to be a challenge. Do you know if there's other health ministers around the country who are going to take bold steps like you did when you were health minister and actually create more medical enrollment spots?
Sure. And in fact, throughout Canada now, there's more than 800 first-year undergraduate positions that have been added in the last, say, 9 or 10 years. So that orthodoxy of the early 90s that you mentioned, Mr. Ray and other premiers at the time. I think actually Bob Ray admitted in his memoirs that one of the worst things he ever did was cut medical school enrollment, which is saying a lot because he did a lot of bad things. But regardless of that, we are reversing the trend now, and we are seeing some improvements on that. Northern Ontario School of Medicine is a big success story, and I think there are other provinces that are looking at opening new medical schools as well, which of course I'm very encouraging of that process. You know that it's a success when both sides at the table here are sparring over who should take the credit for the Northern Ontario School of Medicine. But you're right, I did announce that, and I'm very proud of it. And if there are any we'll have our first graduating year this year since that school was created. And if any of them are listening, please stay in Canada, and please consider Parry Sound Muskoka.
Or Oak Ridges Markham.
Yeah.
Thank you very much. Now we'll move on to Madame Wish-Alice. Welcome back.
Thank you very much.
You'll
I
get your 10 minutes.
But thank you for juggling the schedule so I could get my time in with the Minister. And forgive me if I ask anything that anyone else has asked, but I want to focus on the state of our healthcare system, of which we've been hearing so much as we deal with the 10-year review of the Health Accord. And I guess what I'm a little miffed at is that, in fact, in your address today, you don't even mention the terms national health care or Medicare or the Canada Health Act. There has been no attempt on your part to deal with, that I can tell from either the estimates or your speech or your actions, that would say to me and to Canadians that you are concerned about the erosion of our healthcare system and the growing evidence of people having to pay for things they need, the rise of private health clinics, the growth in P3s, just the incredible erosion of our system, without any sense that you're going to hold provincial governments to task and try to craft a system that resembles Medicare and builds on our principles. Is there anything you can tell us that you believe in terms of health care? I know in the House, when I've asked you questions, you say you're a great believer in the single payer system and in the 5 principles of Medicare. But it seems to me that what you're doing is sitting back and letting privatization, commercialization, erosion happen by osmosis, by stealth. And I don't see leadership from you to actually fix the problem. In fact, we see the opposite. We hear about obviously the money in the budget for P3s, which by all accounts is going to lead to further problems in terms of public health care. We hear about a federally sponsored trade mission going to the Caribbean to support private clinics that are marketing surgeries. We hear all the evidence from the provinces and no action from the federal government. So I think Canadians deserve to know what your plan is to save Medicare.
For the question, I think you unfortunately weren't here when actually you were beaten to the punch by Mr. Fletcher.
Oh.
From our member from Winnipeg here, who asked me a little bit about the
I didn't think anybody was going to ask this
Health
question.
Act and how our party and our government is supportive of the CHA, and certainly we are interacting with the provinces and territories as they innovate their system to ensure that what they consider would be within the bounds of the CHA. So I will continue to play that role, and I play that role quite forcefully, I think I should state for the record. I think it would be fair to say, though, that we have been worried and concerned about the sustainability of the healthcare system. That's precisely why one of our 5 main promises in the last election was the wait time guarantee, and why we were so proud to at least launch the process to have 10 provinces and 3 territories have at least 1 wait time guarantee to start with. Some provinces, like the province of Quebec, have announced 3 wait time guarantees, and through our pilot projects we're announcing more wait time guarantees. And these wait time guarantees are all about reducing wait times, increasing the accessibility of the system, all within the public system. Let me state that for the record, all within the public system, and using innovative managerial techniques and administrative techniques to make progress as well. So I think that we are, in fact, on the same page on that.
Well, I appreciate that, although, you know, we've had good testimony from the Wait Times Alliance folks, and most will say that, you know, the improvements in wait time issues is so slight to hardly be to be noticed in many cases, and has not made a big impact on people's need to access the system on a timely basis. Here are the crises we're facing overall in Canada, and I don't hear you mention any of them in your speech. A health human resource crisis, whether we're talking about doctors, nurses, technologists, and all other healthcare workers and professionals. On every front, a serious shortage and crisis. We have a national pharmaceutical strategy for which there has been no action on your part or your counterparts that I can tell, and it's sitting on the shelf gathering dust. There is no national emergency room strategy. There's no national birthing strategy. There's no national, and I could go on and on. We've had so many representations from groups saying, in terms of a pan-Canadian strategy that will deal with the serious shortcomings of the system and help us, sustain Medicare and build on it, there's nothing. We don't even have an extension of the human resource strategy which has ended as of now. There's no new program. Instead, we have in the budget, there's little cuts here and there, no sustaining program. There's cuts to First Nations Inuit Health. There's cuts to the Human Reproductive Agency. There are cuts to the Patented Medicine Prices Review Board. There are cuts to graduate students and postgraduate students in public health. There's cuts to HIV and AIDS. There's cuts to the Public Health Agency. In every instance where you'd expect to see some focus, some vigor, some energy, you're retreating. So where is the pan-Canadian strategy that is desperately needed on so many fronts?
Sure. It would come as no surprise to suggest that you and I might disagree on interpreting these things. We're the first government in the history of the country to have announced a national cancer strategy. I noticed you didn't mention that. We are well on our way on a national cardiovascular strategy, and those two diseases together account for the great majority of deaths within the healthcare system within society. We've retooled the national diabetes strategy. We've been working on a number of other disease-specific strategies, and we will continue to do so. We have a strategy when it comes to obesity. We have a strategy when it comes to kids' health. So these things are ongoing, and we will continue in that front. I would say to you that you were not here for the health human resources discussion we had, but I did mention that there is within the Health Accord a $38 million per annum fund, which we use with the provinces to assist them in some of their strategies, whether it's international graduates or whether it's, as we just finished talking about medical schools and new places for health human resources within the education system. And I did mention as well, but for 3 years in a row, we've actually taken more doctors from the United States than the United States has taken from us. So we've had a brain gain in those areas. So I'm not saying we're beyond the point of crisis. I'm saying that we are making steady progress, and the federal government is part of the solution.
Do you think we actually need a national health human resource strategy that has clear targets, has an understanding of where the shortfalls are, and has some serious tenets to it that will give hope to people?
Well, I would put it to you that when you look at who has the levers to make the most difference, whether it's the colleges, the regulatory colleges, whether it's credentialing issues, those kinds of issues, access to residence spaces, medical residence spaces, those are all the provinces. And we are funding the provinces more and more every year, but I don't think it is helpful. Dr. Bennett made an interesting point about getting along with provinces, which we are doing when it comes to health care. And I respect them for the role and responsibility they have, just as they respect me for the role and responsibility I have.
I think the province would love to see some concerted leadership on your part, the kind of leadership we saw many years ago when the federal government actually got involved in setting up schools of medicine. I think we're at that kind of situation where it begs for serious initiative on the part of the federal government, because we're dealing with not just a provincial, local, territorial issue. We're dealing with something that has to be dealt with on a national basis, or we lead to raiding and serious problems jurisdiction to jurisdiction.
Well, we're certainly not denying that there's an issue, and I guess what I'm saying is we are working with the provinces and territories.
One area where there's serious lack of any kind of national strategy, which we desperately need given the aging population, is there's no attempt on your part to work towards national home care or community care program. Instead, what we seem to have is is cuts. I mean, you've eliminated, you or the Liberals or both of you eliminated the Secretariat on Palliative and End-of-Life Care, things that a vital pillar of a program that is needed in terms of an aging population. Where is the program for home care, continuing care, palliative care in your branch? Where's the national strategy?
Well, you know, I would say to you as an honourable member that sounds like you're making a bid for the provincial leadership of your party. I mean, I don't.
No,
I
I've
don't
been
see
in the
why.
provincial government. I'm now here federally because
So
I believe
you of all
the
people should
federal
know.
government has a very important role.
You of all people should know that these, you know, the federal government to get involved, you know, in a home care and in community care, we fund the provinces to do that, and they obviously are in charge of those files.
So
we're not going to get involved.
So you don't
Thank
agree
you
at all
very
with
much,
the
Madame
10-year accord which
Micheli-Salis.
talked about national home
Thank you.
care?
Thank you. Now we move on to.
The other 5 minutes now?
We'll let you have a little rest, and then you can continue later. Recoup. Monsieur Malo.
Just 2 hours.
It's my time.
Oh, sorry. Go ahead. Go ahead.
Merci, Monsieur le Président.
Thank you, Mr. Chair. Minister, thank you for being here today. A couple of questions for you that are quite straightforward. Now, you know that the list of products that need to be evaluated to be put on the market is getting longer. There are not enough inspectors. So a number of natural products are still in the pipeline and are waiting for the opportunity to be sold safely on the market. In the 2008 budget, there is $213 million over 2 years for the safety of drugs and consumer products. How did you reach that amount? And how will that money be spent? How many new inspectors will there be? And with this $113 million over 2 years, will this list of products be shortened in a substantial way? So this funding addresses all the objectives under our modified system to address today's problems. I should point out that there will be more employees to tackle these challenges. In fact, there will be a doubling of the number of inspectors under this program. Now, if this bill does pass, well, perhaps the situation will be improved. Well, hold on, Minister. Will the number of inspectors be doubled? Well, so how many will there be in total? Well, 40. 40. You mean it'll be 80 now? 80 when it's doubled, at least. So there'll be at least 80 inspectors. And that is only for consumer products. There are inspectors for other purposes, such as drugs, foodstuffs. And what about improvement as to licensing? How many more products will be assessed and evaluated? Well, we will have a different approach, a risk-based approach.
The risk is relatively small. The burden and oversight can be less because the risk is small. If the risk is greater, obviously the burden and the oversight is going to be greater. Peut-être le sous-ministre peut ajouter quelques mots.
So my colleague can add something. Well, thank you, Mr. Chair. We have a three-pronged approach: prevention, targeted monitoring, and quick response. And this is for all three areas, that is consumer products, food and drugs. Now, a big part of this is having a sufficient number of people out on the ground to do the work. Now, we've got resources the necessary resources to implement this plan. I can't actually give you a figure on this today, but we do intend to increase the number of inspectors out in the field for each of these areas. And says Mr. Marleau, and give the inspectors other tools to do their job properly. Yes, obviously, that's the case. And in the new bill, what's important is the modernization of our legislative framework. If you compare Canada to other countries, there are major deficiencies in Canada's current legislation when it comes to the authority to recall products and inspectors' other powers, and also with respect to fines. Thank you very much, Mr. Malou. Already, my time's up. 5 minutes has run out. Really, Mr. Chair.
I think Mr.
Tilson's going first. Yeah.
Pardon me.
I'm going to ask a quick question then, Ms. Davis.
That's great.
Yeah. I'm going to ask a question on the investment of seniors. And the last census, the 2006 census, showed that the population of seniors over 65 passed the 4 million mark. 1 out of every 7 Canadians is a senior citizen. And your riding, of course, is the cottage country. More and more people are moving to areas such as yours and living in those areas, retiring in those areas. And the question is whether, of course, they have the facilities to serve seniors, whether they have facilities that are designed for seniors. And so there's no question that the Government of Canada is committed to ensuring that policies, programs, services meet the needs of seniors. My question to you, Minister, is what is the role of the Public Health Agency of Canada in regards to the healthy aging of seniors?
Sure, and Dr. Butler-Jones, I'm sure, would be pleased to add some things, but let me just say at the outset that, of course, many of our policies are going to have a very positive impact on seniors' health and seniors' welfare. When I look at the National Cancer Strategy, for instance, when I look at our cardiovascular strategy, when I see what we're doing for seniors' mental health as part of our mental health strategy, all of these things have an impact. Drug safety, food safety, product safety, these can all have a very positive impact on seniors' health and safety as well. But perhaps Dr. Butler-Jones might.
Well, just as certainly, Minister, just as a couple of illustrative points. One, which is a bit of an overarching, we worked and funded WHO for a broad multinational look at age-friendly communities, age-friendly cities, and as well as age-friendly rural areas, and what are the components that actually support healthy aging, and not just for seniors, but for all ages, everything from falls prevention to what are the kind of characteristics of community that are supportive, as well as working with other departments of government and across different sectors around elder abuse, around falls prevention, around emergency preparedness. In other words, how do communities respond and ensure that we avoid the tragedy of Paris, where in the heat wave where many seniors died alone in their apartments as well. So really those are just some illustrative things that fall into a broader framework of what is it about communities that make them more conducive to the health and well-being of people of all ages, and in particular in this case of older persons.
Go for it, Pat.
Okay, I just want to add a quick question on the end here, and this perhaps is for Dr. Butler-Jones as well, but I think it's the Public Health Agency of Canada. For a lot of years, you've had a number of programs and initiatives targeted to pregnant women or women who may become pregnant in that childbearing age. encouraging consumption of healthy diets and regular physical activity and those types of things, discouraging smoking and consumption of alcohol. And I think last year you launched the first national advertising campaign to promote this healthy lifestyle. And it's my understanding that the second wave of this campaign is currently underway during this month. I wonder if you could tell me what the federal government is doing to help young single women lower their chance of having an unhealthy pregnancy.
Right. Sorry, Minister, would you like me to speak to that? Certainly. I think the issue is that for support of healthy pregnancies, well-being, and we have to think well before the pregnancy even occurs, and that's why it really requires partnerships that cross over different levels of government, different sectors, voluntary agencies, etc. One of the things that we do is to kind of gather up best evidence and to have, for example, the Healthy Pregnancy Campaign and information for women of whatever age in terms of what are those factors that they can do, and then how we as communities can support or create environments that are more supportive of healthy pregnancies, everything from the things that we do as individuals, but also getting good medical care through the pregnancy, having systems in place, etc., as the Honourable Member mentioned about the importance of how these pieces come together. And we play one piece of that. Most of the action happens obviously locally, but we try to contribute in a way of pulling the pieces together and illustrating the kinds of things that we can do to actually improve the potential good outcomes and consistently, hopefully, good outcomes of pregnancy.
Thank you. Madam Wichalisalis.
Thank you very much. I'm very concerned to hear today that you, Mr. Minister, have dismissed the idea of any kind of role for the federal government in providing home care or community care. That's been a long-standing belief, tenet among Canadians, sort of the next stage of Medicare. You've dismissed it as something that's strictly local. And frankly, I find, without being disparaging to provincial governments, I find that your whole approach today is very provincial, very local, not national. You suggest that by raising these questions, I should be back in Manitoba running for provincial politics. Well, I suggest to you, Mr. Minister, that in fact what we desperately need is a national vision around health care. And nowhere have you described your vision. Have you put down on paper or said to this committee or the House how you intend to sustain health care? At your convenience, you use the argument of provincial jurisdiction. So when it comes to home care, you're not going to tamper with provincial governments. But when it comes to when it's convenient to you to put on this front of being tough on drugs and consumer products, you're going to tell the provinces, tell all the hospitals in all the provinces that they must collect information on adverse reactions. So when you want to, you do it. When it's convenient to you to do it, you will. But not when it comes to building on Medicare, which would be advancing, as many experts in the field have always said, going from hospitals and doctors to drug coverage to home care to community care. And frankly, I'm absolutely appalled at the lack of vision coming from you and your suggestion that there's no room on the part of the federal government to engage in these areas. I guess my question is, have you totally dismissed the idea of national home care? Have you totally dismissed the idea of a national pharmacare strategy? You talk about a national cancer strategy, which is great. Everybody appreciates that, but it stops short of research and prevention issues. You draw the line conveniently between research and development of drugs and prevention, and ignore people who are dying of cancer. You won't. So I don't mean to exaggerate. I don't mean to exaggerate. I'm sorry. I will take that back.
Thank you.
To suggest that palliative care has no place in the federal regime because you have cut back. There is no longer a palliative care office, and you say there's no place for a national home care program to help those who are in need of supports when they're trying to deal with cancer or heart disease or any other issues. So I'm asking you if you couldn't complete the picture and try to approach this from a holistic point of view and from a national perspective with some vision.
Sure. No, I appreciate that, and certainly I wish to ensure that the record is accurate on this because, of course, the federal government is involved in home care and the federal government is involved in community care. It's called the transfer payments that have increased this year alone by 6%, $1.2 billion extra dollars to the provinces, and I don't think if you and your party wishes to run on creating a whole new level of bureaucracy to deal with home care rather than transferring the home care funds to the provinces so they can deliver better home care, you can run on that. Go right ahead. But I'm not here saying we're going to have a whole new level of bureaucracy for home care and community care. You talk about national vision. In my role as health minister, we're focusing on the things that the federal government should be focused on. And we let the provinces do what is right in provincial areas of jurisdiction. If the NDP wants to run in our country on something different from that, I welcome you to do that. But our vision on health care is, the federal government for 40 years didn't overhaul product safety, for 40 years didn't overhaul drug safety and food safety because they're too busy meddling in the affairs of the provinces. So I'm letting the provinces do what they have to do, and I'm going to do what we have to do for Canada.
Thank you very much, Mr. Minister. Thank you. Mr. Thibault for a couple of questions.
Well, actually, because we're so short of time, I'm going to put two questions to you in the comment, and if you have time to deal with them now, but if not, if you could get back to the committee on them. First, I want to thank you for staying beyond the regular hour and being for so long at the committee. Unfortunately, votes cut us short. But I want to come back on the question of surge capacity. You're a former Minister of Health provincial. You were Minister of Health in Ontario during the SARS time. You said that then, I personally feel that we have to build in more surge capacity. All the hospital administrators across the country are telling us that that's a huge problem in the case of pandemic, in case of other, especially when you would get yourself in a situation where your frontline workers would be at risk and would be the first affected. So that we need that surge capacity. I recognize it's provincial administration, but I believe there's a federal role. And this is the suggestion that I would like you to consider, is that if in the federal-provincial relations in all departments across the board, I think if we look at what we do on social housing, if we look at the role that CMHC could play, a role that it has played in the past, and I think it could play again, in helping to build home social care, nursing home facilities, that type of questions, so that at least we optimize our frontline hospitals and not have that bed-blocking capacity. I think it will help in emergency medicine and it will help in surge capacity and has those potential. The other area question for me, first I'd like to bring another point that I've discussed with you in the House in the past. In the bills that you're bringing forward now, it gives, and I know we'll be discussing them fully, but it gives authority where there was not authority before. And there's always a danger that seems to become responsibility that must be used at all times. Right now, your department advises Canadians of health risks of certain foods, of certain behaviors, and that's fine, that's necessary. But sometimes it crosses a line, and we had one this week on lobster tamale. And it's telling Canadians an advisory that there's a risk to lobster tamale. And it's from the Department of Health, which has great reputation and Canadians trust. Then when you read on, if you read to the third paragraph, it says if you eat more than the lobster tamale of two lobsters a day, there may be some risk of paralytic shellfish poisoning if it happens to be in that population of lobster. I mean, it's a very, very remote risk, but you risk putting at risk $1 billion industry to coastal Atlantic Canada. So I want, my question to you that you could respond, what process do you talk to the Department of Fisheries and all those things in the provinces before putting out the advisory? And the one question, perhaps if there's time that you could answer now, is on the question of assisted human reproduction. Assisted Human Reproduction Act. The Act has been in place for a number of years now. A couple of years ago, we got the first set of regulations. under signing to consent. Where are all the others? Where are the 7 other set of regulations? Why haven't they been coming forward, and when can we expect them?
This fall.
This fall, the 7th?
Thank you.
There's some more coming this fall.
Thank you. I think, Minister, if you could respond to the other 2 questions, send your response to the clerk, that would be very much appreciated.
I think that's probably the wisest way.
And thank you very much. Before we go.
Could I just say that we, as a committee, had requested from the Minister and the Department a full analysis of the 10-year plan. We have not received it as all we've received is a bunch of other reports.
Madam Bennett.
Can we just directly ask the Minister for a proper report of the 10-year plan?
I think we just move on to the vote.
No, Mr. Chair, this is very important. We asked, it was a motion of this committee to get a proper report from the 10-year plan.
We're out of time.
Your department has sent, Minister, instead, a list of
Bennett.
Of Health Council reports, a whole bunch of things. I want the departmental report on the 10-year plan.
Mr. Chair,
we've asked for it to be tabled.
Madam Bennett, we will. You can move that as a motion next meeting, but that's not a point of order right now. We need to vote, as you know. Shall vote 1 under health carry? On division. Shall vote 5 under health carry? On division. Shall vote 10 under health carry? On division. Shall vote 15 carry? And let me put vote 20 to 45.
On division.
All on division. Thank you. And shall the chair report vote 1 to 45 under health to the House?
Yes.
Thank you very much. Meeting adjourned.